Next, okay. Good. Nothing weird in the background, just my bed. Cool. Let's go.
Let's go. So hello, thank you for joining us. If you're live with us. And also hello to everyone who's watching the recording. My name's Sophia. I'm one of the F1s working in North Manchester, and this is Ron. And
Hi.
we're going to be presenting nephrology. So just before we get started, if you've been coming to our sessions, we're doing a quick survey that our research lead is running. You have to see all the details on that survey, and you can get involved. So moving on, so it's going to be about an hour-long session, as with all our other sessions, and we'll be covering the topics on here. And we've used the MLA content map to ground our questions. And having done the MLA ourselves, we'll be able to let you know what kind of questions can come up and what are the common things that you actually really need to know. So we'll give you about a minute per question, in which time you'll be able to answer it in your own time, and then we'll go through each answer individually. So 10 questions. First question starts now. So you're 58, you're not a 50-year-old, you're a male. You're an FY doctor who has a 58-year-old male patient on a surgical ward after undergoing a total nephrectomy 2 days previously. He appears well, and the examination findings are normal, although his urine output has dropped. His fluid chart shows he's passed 850 ml of urine in the past 24 hours, and he weighs 80 kilos. So blood tests show creatinine rise to 100 micromoles from a baseline of 90. What's the most likely underlying diagnosis? Okay, I'll give you 10 more seconds. Three, two, one. So this question is asking whether you know the criteria for an AKI and what oliguria actually means. So the answer to this question would be D, so an AKI. And I'll go through why. So I think some people put normal physiological response after surgery. So you can expect oliguria a few hours after surgery. And that's a normal physiological response after any sort of surgery, whether it's brain, heart, or kidney surgery. But that tends to resolve after 1 day. So he had his nephrectomy 2 days ago, and anything after that, you would consider an AKI. So post-nephrectomy oliguria, there's a question of whether you'll get oliguria just by having one less kidney. And the answer is actually no. So you still produce the same amount of urine, even if you have one less kidney. And that's because your existing kidney can compensate. So why it's not C, so benign prostatic hypertrophy can happen in 58-year-old gentlemen or elderly gentlemen, and it is a common cause of AKI or obstructive AKIs or post-renal AKIs. But there's nothing in the stem to suggest that he has an enlarged prostate. But as part of your workup, you could consider an examination to see whether the prostate is enlarged. And SIADH, so you can get SIADH, which leads to oliguria after surgery, but it tends to be more common after a pituitary surgery rather than a renal surgery. But if you thought that SIADH can occur after any sort of stress, you'd be correct. But in order to diagnose SIADH, you would need to do urine and serum osmolality. And they don't mention this in the question. So yeah, so this is just the calculation that you would do according to the KDIGO criteria. So doing 0.5 times by his weight times by the number of hours, you get 960 mils, which is more than what he actually passed. So just a quick summary of AKI, something you just have to learn and remember. The way I try to remember is like 6, 12, 24 for stage 1, 2, 3, and then just rote learning 26.5 micromoles in 2 days, increase in serum creatinine. Those are the main ones, this increase in serum creatinine and the urine output. And then in stage 3, you could also get anuria for 12 hours. And then on the right, it's just a brief summary of the most common causes of AKI. If you think of it as pre-renal is anything to do with the blood. So you have a reduced circulating volume. It could be because of heart failure. It could be because of sepsis or blood loss, dehydration, anything that reduces your intravascular volume. So there's less blood going to the kidney, so the kidney also outputs less. And then your renal problems are anything to do with the nephrons or the tubules or the glomeruli themselves. And they tend to also present with some hematuria because the glomeruli are malfunctioning. And so they're letting like basically anything go through that wouldn't normally go through. And then post-renal, so in men, the thing that you think about the most is the prostate. So that's when your consultant would ask the poor FY1 to do a PR exam when they don't really want to do it. And then you just see if the prostate is enlarged. But it could also be other things like intraluminal obstruction or extraluminal obstruction. So intraluminal could be all sorts of cancers, and extraluminal, again, more cancers, but could be pelvic in origin or gynecological in origin. So we'll just go through the workup of an AKI. It looks like a lot on this screen, but if you just memorize the basics. So your basics in any scenario, especially in an OSCE, if they're asking you for what will you do next, and you're presented with this patient in an AKI, you'll say, I want to do bloods, bedside tests, imaging, and consider some special tests. So if you remember those 4 categories, so in your bloods, you're going to think about FBCs you use and use, of course, and all your basic bloods and your bone profile. Bone profile would show your calcium levels and all these sorts of electrolytes, including magnesium and phosphate, can impact on your kidneys. So that will be your bloods, bedside tests. For some reason, consultants get really aggy if you don't do urinalyses. So any sort of urine dip, if you ask for it, ask the nurses for a urine dip. And then ask for any sorts of urine cultures. You can take a set of OBS and ECGs. And then your ABGs and BBGs can also indicate sort of lactate levels and whether this person's in any sort of metabolic acidosis, which can also affect the kidneys. Imaging, so the most common one that you would do on the ward is a bladder scan. And if it's over, I think, 500 mils, it indicates that you're in retention. So that would indicate that you've got a post-renal obstructive cause. But you could also consider renal ultrasound if you're thinking there's some sort of hydronephrosis. A CTKUB could point towards any stones, and fundoscopies. Fundoscopy in the eye, I can't remember why I put that in there, but it was on the BMJ best practice. And then special tests, you can consider renal screens and biopsies, but that would be after you refer to renal, so that's not something you would order as an FY1. And then in terms of management for an AKI, I think of it in terms of supporting the patient first. So correcting any hypovolemias, giving them fluids. I think the default for any FI1 presented with a patient with an AKI is just prescribe fluids. So you can always start with that because that's the easiest to correct. And correct any hyperkalemias. And then second step would be to review. So review the causes of the AKI. So review the medications, think about the toxicity there, review the bladder scan. There was a case on my ward where a patient was in AKI for 2 weeks and people just kept giving that patient fluids. And it turned out they were on everolimus, which is a chemo drug, and it only got picked up really, really late in the game. And once that was stopped, the AKI slowly started improving, but unfortunately that patient sort of deteriorated a lot after that. But just to be aware that there are lots and lots of medications that can cause AKI. And then the last step after supporting them, reviewing medication, is to escalate. So alerting a senior early about an AKI is important. And it might seem like it's a small thing, but it's something that can deteriorate quite quickly. And then refer to nephrology if they've got any sort of CKD4 or they've got a renal transplant, if you think it's an intrinsic renal disease, or if dialysis is indicated. And we'll go over the indications for dialysis in another slide. And since I was on radiology, I thought I'd sprinkle in some radiology here. So on the left, you've got the ultrasound of a kidney, and you can see it's quite hydronephrosis. So all that black stuff is all the liquid that's gathered in the pelvis of the kidney, and that's normally very thin, and it looks like tree branches, but this you can see is quite dilated. And that's something you can do at the bedside as well if you're trained, and it's just a scan on the patient's back. And on the right, you can see this is a CT scan of a transitional cell carcinoma in the bladder causing obstructive AKI. And if you were to just prescribe fluids to this patient, they would not get better. So that just shows that you need to think about the causes of AKI. So next question. The 72-year-old Caucasian man presents to his GP with bilateral lower limb swelling, and he has type 2 diabetes, which he manages with metformin. On examination, he has pitting peripheral edema, a clear chest, and normal heart sounds. He has a normal full blood count and beta-type natriuretic peptide, but elevated triglycerides, hypoalbuminemia, and serum creatinine of 167 micromoles. His protein creatinine ratio is 490, and his urinalysis showed no blood, and protein was +++. What is the most likely underlying diagnosis? Okay, give you 10 more seconds. Okie dokes, so this is a question that tests your knowledge on intrinsic renal diseases. And I remember as a med student, I hated intrinsic renal diseases. So this one's really asking you whether you know the most likely ones to come up. So the answer for this would be D, membranous nephropathy. And if you know your intrinsic renal diseases, you know it's one of the most common, especially among the elderly population. Whereas if it's a child, you'd immediately think minimal change disease. And they're kind of on a spectrum of proteinurias. But because of this patient's demographic, you'd think membranous nephropathy. But there are other things that point towards it too, such as the hypoalbuminemia and the elevated triglycerides, and the fact that there's no blood. So you already know it's a type of proteinuria, and the elevated triglycerides are associated with membranous nephropathy. So why it can't be heart failure is because proBNP is normal, so you can rule that out. Minimal change disease, it's possible to get that in an elderly population as well, but again, as I said, it's asking for the most likely diagnosis, and minimal change disease would be most likely in children. IgA nephropathy falls under the spectrum of hematurias, and you would expect something in the question that would point more towards an IgA nephropathy, and there's nothing in here to suggest that. IgA nephropathies, you would think about an infection and then hematuria a couple days afterwards, but this guy doesn't have any signs of an infection. And then diabetic nephropathy, again, doesn't suggest that he has, well, he does have diabetes, but he's only managed on metformin, so you can tell it's sort of a mild form of diabetes, and diabetic nephropathy is it can happen quite early on, but it's unlikely to cause the sort of protein pluses that we see here and the bilateral lower limb swelling. So the most likely is membranous nephropathy. And I do have a slide on big table to explain it all in a few minutes, but I have a couple more questions to ask before I give you that table of gold. So nephrotic syndrome, so it's defined as proteinuria of more than 3.5 grams over 24 hours, peripheral edema, and a low serum albumin. I think in practice, as soon as you see a patient with peripheral edema, you're thinking heart failure or nephrotic syndrome. So it's about ruling out each one. Clinical features, you could get some frothy urine, swelling all over the face and body. You could get weight gain due to fluid retention. You might get hypoalbuminemia, fatigue, and hyperlipidemia. And in terms of investigations, it's the same 4 broad categories that we talked about in AKI. So if, again, OSCE examiner is asking you, what would you do next? You would say bloods, bedside tests, imaging, and special tests. So in terms of bedside tests, you can also add a protein and creatinine ratio, which would just give you a better idea of how much protein they are excreting. And imaging, if you're thinking about ruling out heart failure, consider a chest x-ray, also consider an echo if the proBNP is elevated. And in terms of special tests, I've listed them here. That's part of your renal screen, but you wouldn't be expected to order each one of these as an FY1 without sort of special guidance. And then if you want to score extra marks in an OSCE scenario, you say you would also investigate for cardiovascular risk factors, because a lot of nephrotic syndromes are associated with sort of poor lipids, poor glucose management. So saying that you would manage these cardiovascular risk factors could get you extra points. And then you could also investigate for the complications. So because your blood is, you're sort of excreting so much protein and you're hypoalbuminemic, you could also experience some hypercoagulability in your blood. And so you could consider sort of coag screens, Doppler ultrasounds, but that would only be if they present with sort of swollen, well, they will have swollen legs, but if it's like painful and you're thinking to ruling out a DVT and things like that. And then thinking about vitamin D in any elderly patient is really easy to replace. So in terms of management of nephrotic syndrome, again, 3 key steps. So I deal with the acute problem and support them. So we can fluid restrict and salt restrict, and that would help to offload the extra fluid that they have. And you can monitor that with daily weights. Get some dietary input as well, and consider TEDs or some kind of VTE prophylaxis. And then the second thing, as with AKI, would be to review and combat the cause. So you'd be thinking about the use of steroids or immunosuppression after you have renal input, or like specialist renal input. And then the last one would be to optimize your renal protection. So secondary prevention, could consider ACE inhibitors, your statins, vaccinations, but that would also be a decision made in conjunction with your consultant. So question 3. You're not a 26-year-old man. You're an FI1 doctor looking after a 26-year-old man who presents to A&E with shortness of breath and hemoptysis, and he has been feeling generally unwell for the past 3 days and started coughing up blood this morning. He smokes 10 cigarettes a day, but otherwise has no past medical history. His creatinine is 200 micromoles, his baseline is 90, and a urinalysis shows protein ++ and blood +++. An intrinsic cause of AKI is suspected, and a renal biopsy is performed. What would you suspect to see on your renal biopsy? Oh, thank you for Paul. This one might be a little tricky. Either you know or you don't know it. Okay, so the answer is C, formation of epithelial crescent in glomeruli. So I'll talk through this one as well. So this gentleman has a case of pulmonary renal syndrome. So he's got shortness of breath, hemoptysis, and he's got elevated creatinine. You already know he's in some stage of AKI because he has more than 26.5 increase, micromole increase in his creatinine. So there are only a few conditions that cause pulmonary renal syndrome. And one of the most common ones, well, actually it's not that common, but one of the ones that immediately comes to mind would be anti-GBM. So trying to think about which of these findings would correlate with anti-GBM. So it's where you have antibodies that attack the basement membrane in your kidneys, and they form sort of like a moon shape on the biopsy, and that's the fancy name for it is the epithelial crescents. So that's how you'd reach that answer. Let's think about the other answers here. So the tram track aperients, that's because you've got all of the reactions happening in the nephrocytes. So it's most commonly associated with membranoproliferative intrinsic renal disease. Again, something that you just have to memorize. And I kind of think of it as membranoproliferative is associated with Hep C and infections. And I think of it as like, if you go on a train, you're likely to catch infections. And so that's how it's related to the Hep C and Hep B. But you think of your own odd ways to remember it. And then the effacement of the foot processes and fusion of podocytes, that's the finding for minimal change disease. And I think of it as like, again, it's another silly way to remember, but babies have really cute feet and children are most likely to get minimal change disease. So that's how I remember it. But again, you'll think of your own ways. And then we talked about the crescent, the moon shape for anti-GBM. Starry sky appearance is associated with post-streptococcal. I think of it with the S's, so starry sky, post-streptococcal. And then mesangial IgA immune complex deposition. It's in the name, it's IgA nephropathy. So pulmonary renal syndrome, associated with good pastures. So a bit about anti-GBM. It is associated with these antibodies attacking the type 4 collagen, and it's a type 2 hypersensitivity reaction. Again, something you just have to memorize. Anything with antibodies is type 2. And you'll get hematuria and hemoptysis. So your respiratory symptoms would be like chest pain, coughing up blood, shortness of breath, and you might feel a little bit fatigued. And investigations, again, we've got the 4 basic categories: bloods, bedside tests, imaging, special tests. You know it all. And in terms of management, it is mainly supportive. And then after you refer to renal, they would likely recommend suppressing the autoantibodies with steroids. As we know that steroids is the answer to all sort of immune stuff. And we could consider cyclophosphamide as well. Then once we suppress the anti-autobodies, we want to get rid of them. So you can do plasma exchange, and then you would also consider dialysis and renal transplant. In exceptional cases, they do sort of bronchoscopies with embolization. That's only if they're bleeding heavily and they're coughing up a lot of blood. But it is important to be aware that the pulmonary complications are the most common killer in patients with anti-GBM. So this is a good image to screenshot. It's a nice summary of the nephrotic to nephritic intrinsic diseases. So if there's blood, you're thinking nephritic, you're thinking about your anti-GBM, vasculitis, IgA nephropathies. And if it's more nephrotic, there's no blood, you've got mostly protein, you're thinking about your minimal changes, membranous nephropathy, FSGS. And so I've created a little table for you. So you've got the definition on the top row. I won't go through each one of them, but it's got some key renal biopsy findings that they may ask you in the MLA, and some key clues that I use to remember it. You can edit this table if you like with other clues that you find would be helpful. So nephrotic syndromes, and again for nephritic syndromes, I think a common question is differentiating between post-streptococcal and IgA nephropathy, because they both similarly present with some sort of infection that leads to hematuria. But in IgA nephropathy, the hematuria happens like 1 to 3 days after the infection, whereas in post-streptococcal, it happens 1 to 3 weeks after infection. So, question 4. 49-year-old man with multiple comorbidities presents with dark-colored urine and ache-like pain in his forearms and thighs. His years and years show elevated urea and creatinine of 210, baseline 90, and his CK level is 2000. He recalls starting a new medication 2 weeks ago. Which of the following medications is the most likely precipitator? Again, it's either you kind of know or you don't know. Thank you for Paul. Okay, 10 more seconds. Okie dokes. So the answer to this one, either you know it or you don't know it, is the statin. So I think quite a few people got that one. And some people put gentamicin as well. So we'll go through the answers. So they've got a dark colored urine. So that could be it's concentrated, or it could be they've got the breakdown products of blood in the urine, especially with a high CK level. So it's rhabdomyolysis. And they've got ache-like pain. They've got this muscle ache in their arms. And it happened 2 weeks ago. So if you think about what medications can cause muscle aches, the only one on here is really a statin, and it can cause rhabdomyolysis in some cases as well. So it's really important when you're doing counseling stations to mention the possibility of muscle aches. Beta blockers, not so much. ACE inhibitors, it can cause kidney problems, but they won't affect your CK levels. Gentamicin, it can cause renal problems. So it can also cause hearing problems. And that's the reason why we try not to use gentamicin in hospital for more than 3 or 4 days. And then after that, you need sort of specialist input. But this question is really highlighting that the CK level is really high and they have pain in the arms. And gentamicin isn't really associated with muscle aches. So that's why statins is the most likely answer here. Loop diuretics could also cause kidney problems, but again, it's not associated with high CK levels. So there we go. So now you know for OSCEs, if you get asked to counsel on statins, remember about muscle aches. So rhabdomyolysis is a condition where the skeletal muscle breaks down and it releases like the myoglobin, and the electrolytes into the blood. And in hospital, you most commonly see it in elderly patients who've had a long lie, so they're on the floor for a long time. But it can also happen in status epilepticus, and the CK levels tends to be in the sort of tens of thousands rather than just the thousands. So it does tend to be about 5 to 10 times the upper limit for it to be diagnosed as a rhabdomyolysis. So if it's only 1 or 2 above the normal, then you wouldn't call it rhabdomyolysis. Clinical features, you get the dark colored urine because of the myoglobin, and the muscle pain might be disproportionate to injury. And again, you have the 4 categories: bloods, bedside tests, imaging, and special tests. I'm going to hammer that in this session. And then special tests, you could consider a muscle biopsy, but you don't really need it in order to diagnose a rhabdomyolysis. And it's supportive management. This is the one case where you can just give fluids. So last question from me. 30-year-old woman, end-stage renal disease, presents to A&E at night. Past 2 months, she's used continuous ambulatory peritoneal dialysis, but today she feels really unwell, abdo pain, and her last bag is cloudy. What's the most appropriate management? Okay, I think people might be struggling a little bit, so I'll give you another 10 seconds. Okie dokes. So this one's a tricky question, and it's kind of testing sort of what would you do as an FY. So the most appropriate management here would be refer to renal. Anything complex, refer to renal, especially if they have end-stage diseases or they're on dialysis, refer to renal. So we'll go through why it's not some of the others. So dip the urine and prescribe steroids. So dipping the urine might not be appropriate because she does have end-stage renal disease. She might be completely anuric. You can always try, but in terms of prescribing steroids, if you're thinking this patient has abdo pain, cloudy, there's a potential for it to be an infection. If you prescribe steroids, you're actually going to make the infection worse if you're hampering down her immune system in this scenario. Option B, refer to renal. They like to handle these kind of things. Option C, IV vanc and ceftazidime. So if you thought about C, you'd be right in thinking, I didn't add ceftazidime into this one, but it was on the previous one. But IV is not an appropriate way to give antibiotics for an infection of peritoneal dialysate. So it's the right types of antibiotics, vancomycin and ceftazidime, but it's not in the right form. So you'd have to give it through the dialysate fluid in order to combat the infection in the dialysis fluid most effectively. So it wouldn't be IV. D, reduce ultrafiltration rates, not really relevant in this scenario because ultrafiltration relates to hemodialysis rather than peritoneal dialysis. And then replacing the peritoneal catheter and giving pure metronidazole. So you try to replace the catheter in any case, but giving oral metronidazole wouldn't quite cut it for the bugs that you could grow. Metronidazole is effective against gram-negatives, but when you've got a peritoneal dialysis, it goes through your skin, and so there's always a risk that you get gram-positive infection as well, because you've got Staph aureus and all these other bugs that are gram-positive on your normal skin flora. So giving just normal metronidazole would not cover the potential infection or the potential infectious causes. So as an explanation, you would require vancomycin and ceftazidime added to the dialysis fluid, but it's really a question of when do you refer to renal? If we discussed it in the first question in AKI, you would refer any patient with end-stage renal disease to renal. So just a quick summary on dialysis. Two types of dialysis. You've got hemodialysis and peritoneal dialysis. The hemodialysis, you do need the AV fistula. In an OSCE scenario, I don't think it's completely out of the realms for them to ask you to examine the fistula. So you just examine for any bruits. And in terms of complications of hemodialysis, just be aware about hypotension, potential arrhythmias and muscle cramps, and then something called dialysis disequilibrium syndrome, which is where the brain kind of really doesn't like the fact that there's so many changes going on in the blood, and it has like a bit of a spasm. And then the patient can feel really confused after that. It's rare, but it's life-threatening. And an AV fistula ischemic steel syndrome is where if they create a fistula in your arm, the blood's going to go directly from the artery to the vein in that fistula. So the blood might not go down to the rest of the hand, because it's found a more efficient route in the fistula. So it means that the blood that normally goes to the hand no longer goes to the hand, and then it ends up ischemic. So that's what that is. And then peritoneal dialysis, it tends to happen over a long period of time. So you leave in the dialysis fluid for a few hours and then you drain it. And that's partly why reducing the hemofiltration rate in the previous question is not quite relevant, because you just put in the fluid and then leave it. But the most common complications of this type of dialysis is bacterial peritonitis, with staph epidermidis being the most common cause. You can also get sort of sclerosing encapsulating peritonitis, which later down the line can cause adhesions in the bowel, and you could get bowel obstruction and catheter leaks. But in the acute setting, reasons why you'd want to send a patient for dialysis and ICU include the AEIOU. So the A is for acidosis, E, electrolytes, I, intoxication, O, edema, and U, uremia. And also if they've got a really, really, really low eGFR. So if you just memorize this slide, I think this one's the most relevant for dialysis. So that's the end of my questions. Sorry it took a bit long, but I'll hand you over to Aaron. Bye.
Fair enough. Yeah, thank you, Soph. Those are some really good slides. My questions, we will take the rest of the time. I'll test just a couple of high yield things, and I'll just go through them, the explanations. So we'll go to question number 6. They're also all based on largely things I've seen on the acute medicine unit, on surgery, and now on infectious disease. Yeah, so you've got a 74-year-old woman presenting to the acute medical unit with fevers, loose stools, and abdominal pain. When you look through her GP records, you note that she's a known chronic kidney disease stage 4 that was treated with a renal transplant about 18 months ago. She's also a well-controlled type 2 diabetic, and she's got a little bit of hypertension. When you look at her bloods, they show a reduced white cell count, a reduced HB and neutrophils, as well as a raised CRP. So given that presentation and the past medical history, what's the most likely cause of a presentation? I'll give you just a couple minutes just to mull it over. Okay, yeah. Next slide, please. So for this one, I've put that she's most likely having a concurrent cytomegalovirus infection. Now, I know that people have put E. coli and Bacillus cereus, and that's great. However, and that's what you would typically expect from the history if they were essentially a normally fit and well person. However, given the kind of the past medical history, if you go on to the next slide, so renal transplants, especially for patients with end-stage renal disease, they often require quite heavy immunosuppression to prevent renal graft or renal transplant rejection. And when you look on the NICE guidelines, you tend to get tacrolimus and mycophenolic acid. So these drugs suppress your immune system, hence the reduced white cell and neutrophil count, but it also means that you're at quite a high risk of opportunistic infections, such as cytomegalovirus. So it's just one of the things that we keep an eye out for. And CMV tends to give very non-specific kind of infective disease type things. Yeah. So that's quite a good point. Always remember, yeah. Always think CMV in a recently ill immunosuppressed transplant patient, to be honest. It could be renal, or it could be just any type of organ transplant. All right. Next patient. or next patient, yeah, next question. So you've got a 34-year-old male presenting to A&E with a new onset frank hematuria, and on examination he's telling you he's got pain in his groin that radiates up to his left back. On examination you find he's got a flank mass, like it's palpable, and when you look further down you can see a left-sided mass that transilluminates in the scrotum and becomes a bit more prominent on standing. So given the most likely diagnosis, what's the anatomical relation to explain what's going on? I know that this is more of an anatomy question. However, there were a couple of these questions on my MLA where they just asked me about specific anatomy bits. So hence I've tried to replicate that on here. It's just it took a couple of people by surprise when it wasn't asking for pathology or treatment options, but how and why things work. So okay, next slide, please. We'll try and get you done just past 8. So don't worry, these are quite quick fire questions. I think Soph's handled most of the high yield information. So yes, the correct answer for the anatomical relation is the left testicular vein drains directly into the left renal vein. So if you go on to the next slide, this is quite a common thing that you get tested on your renal or urology placements. So effectively, if you click on the next slide, a red triangle will come up, and because of that shared venous drainage from the left renal vein or left testicular vein down into the testes up into the left renal vein, if you have any sort of mass or compression on the left renal vein, you get that backflow, and that can present classically on the left-hand side as a varicocele. The key word that you're looking for is it backs up into the piniform plexus. So if you ever are getting grilled by a urologist or a renal doctor on the examination finding, that's the venous plexus that you're looking for. And if you note on the right-hand side, your right testicular vein drains directly into the IVC. So to be honest, accounting for anatomical variances, you probably shouldn't get a right-sided varicocele unless that IVC was getting blocked off, in which case I think you've got bigger problems and you probably be calling vascular at that point. If you go on to the next slide. Yeah, and again, just trying to link it into the NICE guidelines, just because you will probably be tested more on these. So the urgent referrals to your urologist are if the varicocele comes up suddenly and is really, really painful. And again, if the varicocele doesn't drain when you lie down, because as I mentioned, it's all about the venous drainage. So when you lie down, you should have a relief of that back pressure. It goes back into the left renal vein, into the IVC, and you get a reduction of that size. And that's why in the question I noted that it got bigger when you stood up, because gravity is helping all that blood go down into the varicocele and make it bigger and more prominent. I also, if I was being nice, I would have put bag of worms appearance and transilluminate, but I think bag of worms would have made it a bit too obvious. So, all right, next question, please. Next patient. So you're in GP, and you've got a 65-year-old man presenting for an annual well man checkup. As part of his bloods, the GP has reviewed his urinary, which are on the right-hand side. Given his urinary, and I understand this is just a snapshot, but if you were to see these urinary in GP, what monitoring should be commenced by the GP on discharge? And again, I'm just trying to link that into the NICE guidelines in terms of what kind of thought process people would be going for. I guess just generally with these five, or with my 5 questions, I've tried to get kind of 2-stage thinking, but also just test one specific fact. I'm not, yeah, I hope that works for people. Yeah, it's just my own personal style and how it's what works for me. But I know people prefer the safe style, which is a lot better for when you're watching it back. Unfortunately, you have me to contend with my rambling, but yeah, okay. Next slide, please, Soph. So the correct answer, given here's a quite dire renal function, would be for monitoring of calcium, phosphate, and PTH, as well as you'd probably want to refer them to renal. But if we go into the next slide, we'll go through why. So essentially, this man is in renal. Oh, he's in CKD, G4, probably at A1, A2, depending on the albumin creatinine ratio. And essentially the steps in that question were to recognize that he was in such bad CKD. And then remember that when you're, the NICE guidelines say that if you are in CKD 4 or above or worse, then you should routinely have monitoring of your calcium, phosphate, and PTH levels. So that's the learning point number 1. It's a nice guideline. And secondly, is to remember the other functions of your kidneys. So they play quite a role in your calcium, PTH, and phosphate reabsorption. And so when they're impaired, you can start to get dysfunction in the electrolytes, such as calcium. So you can get things like where your body starts to reabsorb the calcium from your bones, and you get hyperkalaemias and all sorts of trouble with your electrolytes. And so you'd probably want to monitor the levels of those electrolyte salts during routine monitoring and also before sending them off for a renal referral. Yeah. All right, next slide. Ready. So you're in PTD, unfortunately, and you've got a 10-year-old female presenting with acute bloody diarrhea after eating at a picnic. She's admitted, and you decide to commence her on steroids and supportive fluid therapy. Despite this, she develops an acute kidney injury, and you note that someone's done a coag, which is great, but it shows a prolonged bleeding time. You take a blood sample and you decide to just have a look at it on a light microscope. I know you found the Ward microscope that I keep getting asked for, and you just have a look. What findings would you be most likely to see on blood film microscopy for a blood film from this patient? Already, next slide, please. So I would be expecting to find red blood cell schistocytes. Essentially, they're red blood cell fragments from when the red blood cell just split off. I think if you click next, you should get a picture. So effectively, what this young girl has is a presentation of the hemolytic uremic syndrome. So I tried to kind of point you towards that with history. So she's eating at a picnic, and you can get E. coli from ill-prepared food. And unfortunately, one of the strains, 0157H7, I believe, produces the Shiga toxin, which can cause hemolytic uremic syndrome. The kind of two causes of HUS that most commonly appear would be your E. coli 0157H7, and I think it's the Shigella Shigella species, which causes a Shiga toxin. Typically, when you send off for a blood film, you'll get burst red blood cells, which you can see on the right-hand side. It also explains the hemoglobin, because if you've got red blood cells bursting everywhere, you're losing them in the blood, hence you get your hemolytic anemia. The uremia was characterized by the acute kidney injury, so I couldn't exactly, well, if I was nicer, I would have put that urea was sky high and you've got a declining renal function. However, it's thought to be mediated by just microvascular clots within the kidneys as well as elsewhere. And the prolonged bleeding time can be explained as you get a thrombocytopenia or a reduced platelet count. That's because the platelets are clotting up the endothelial damage caused by the Shiga toxin. So Shiga toxins go around causing loads of damage, causing the red blood cells to explode, causing kidney damage, microclots, and then your platelets are mopping up, causing even more sticky, clotty fibrin clots that then clot off and cause even more damage. Note that typically your management here is supportive, hence the steroids, and probably just some fluids. Yeah. Next slide, please. Final question. We're set to finish roughly on time. So this is a case that happened to me just before Christmas, and it highlights quite a common thing that happens on the wards. So you've got a 60-year-old man, especially surgical wards, 60-year-old man with end-stage renal failure and peripheral vascular disease presents to the vascular ward, effectively awaiting surgical management. During his admission, he develops a new bradycardia and oliguria, so you've been asked to review. On your review, you do some formal bloods, but in the meantime, you decide to do a VBG, as you'll probably get the results quicker whilst you're waiting the formal bloods, which can take about an hour. It shows a sodium of 135, potassium of 6.3, urea of 8, with an estimated EGFR of 15, creatinine 300, HB of 90, white cells of 4.5, and neutrophils of 5. The ECG is taken, which you can see on the right side. I'm hoping people have enough bandwidth, or the computer's transmitting it well enough to show. Given the results of the VBG and the ECG that you can see, as an FY1, what would be your best initial management for this patient? Again, this happened to me in real life, so I just thought I'd hammer the point home. Okay, right. Next slide, please. Right, so the correct answer, given that the potassium is rather high and the patient is symptomatic, as well as when you look at the ECG, you're starting to get definitive ECG changes. Your emergency treatment to stabilize the cardiac membrane is some calcium gluconate 10%, 30 mils as a stat IV. Next slide, please. And we'll go into your rough workout. So it's very, very common electrolyte abnormality seen on your surgical wards. You can have be caused by your renal failure. Patients can just be a bit dry after surgery. You just had a big stressor response that could have an infection. But to be honest, in the moment, what you need to do is stabilize the patient, do an A to E, get that ECG. And if there are any ECG changes, your immediate treatment is to protect the heart with your calcium gluconate. And then if we go back a slide, so once you've done that, you can then kick into all of the other things that are listed there. So for example, your salbutamol 5 milligram neb can help drive that potassium back into the cells which will reduce the potassium for a little bit. However, that's quite a transient measure. I've tended to find that. So the salbutamol brings the potassium in, and it comes back out a couple of hours later. So you get this refractory potassium rise. To be honest, for most patients, the definitive way that you on the ward can reduce that potassium, if once they're stable, is to give them some Lacalma, which binds the potassium, and the patient then excretes it. However, you'd really tend to do that once you've done everything else. The calcium gluconate, as I've mentioned, is your emergency. That there are ECG changes to stop the heart going into a ventricular or an arrhythmia, which can cause cardiac arrest. Your glucose potassium infusion, or GKI, is typically used for your patients who require insulin, but they're nil by mouth. However, in this patient, given his renal failure and his concurrent nil by mouth status as he was awaiting surgery, I ended up liaising with critical care to use the GKI with some insulin to try and lower that potassium down, but that was a very case-by-case basis for him. And finally, you've got the Hartmann's 1 litre fluid resus. To be honest, unless the patient was hemodynamically unstable or really hypotensive, it doesn't really form a part of my algorithm for lowering potassium. But the other 4, or A to C, is what will be found on your trust guidelines for managing an acute and long-term hyperkalaemia. Yeah, alrighty. Those are my 5 quick questions. Okay, I think that's us. So if you wouldn't mind, we'll send you all a feedback form. Thank you so much for your time. Soph, do you have anything? Just send the feedback.
No, thank you so much for joining, and thank you for watching if you're watching in retrospect. Our next session is next Thursday. I'm just going to double check what it's on.
Urology.
Oh, urology.
Yeah, so it's the surgical side of all of this. So we've done the Bean Man side. That's the nephrology side, and now we'll be looking at effectively the pipes is how I understand urology versus renal. In terms of the MLA, very anatomy heavy, I had maybe 2 to 3 questions out of 120, I believe, that were, what is this in terms of anatomy? Yeah, so it's useful to know, and it's what differentiates kind of your upper tiers of question. So a couple of the questions I got was like the vasculature. So what blood supply does this specific region of the bowel, and also like what's the relation that causes this presentation of numbness. So it's pathology, but trying to link it back into the anatomy. So there's always going to be a link to the disease. It's not going to ask you what's the 5th flexor. There's going to be a link for you to understand. Yeah, I'm glad you found the questions great. Yeah, I appreciated Soph's explanations. I think mine was very much more about 5 things you need to know for renal. Job done. Yeah.
Nice. We're starting our morning as series soon as well on Saturdays. So they'll be different to these sessions, which are topic based or speciality based. The morning as sessions are like morning in a GP, so you'll be like tackling GP questions, morning in A&E, so emergencies, and they'll be taking place on Saturdays. So you can look out for those. I think the first one is on the 26th of April. And also,
yes.
if you're interested in getting involved in the society, we're still looking for university representatives, especially if you're in Scotland, Ireland, and down south near London. So if you're interested in becoming a university representative, please scan the QR code and you can apply on there. And that's it from me.
Alrighty. Thank you very much for your time. I appreciate you all coming. I know it's a lovely day out there, so yeah, I hope you've all had a great day. Yeah, any more questions, just we'll hang out for a couple more minutes, and then we'll probably end the stream.
Yeah. Sounds good. Well, the day is almost ending, Aaron, so it's turning dark. No more questions, we can end the stream.
Yeah, let's do it.
Okay. Bye-bye.